Hello, everybody, and welcome to the Dr. Mike and Shannon Show. I'm Shannon Fanestein, medical specialist with Mazon Medical and Uraval BRS, and we are joined with Dr. Mike Bradley. Dr. Mike Bradley, go ahead and introduce yourself to those who might be new for our show.
I'm Dr. Mike Bradley. I'm a PhD medical researcher. I work with Mazon Medical as their chief medical officer, and I'm very pleased to be able to represent the bulbocavernosa reflex by Uraval through Mazon.
Thank you very much. And today's question, we always have a question of the day for those of you who are new to the show. So today's question is, how can an oncologist be able to use the Uraval for screening patients? And I've had this come up because they have a question regarding patients with ED.
Yes. And we've got the white papers to kind of back up what I'm about to talk about. And we'll talk about that a little bit. But, I was out in Southern California and I was working with an oncologist out there. And I talked with her about bulbocavernosa reflex. And I talked about the term nerve sparing techniques. So an oncologist, specifically with men, will do a prostatectomy. And we'll talk a little bit about the radical prostatectomies that they do. And they use nerve sparing techniques to be able to try to do what they're trying to do and not do so much damage on the patient that it causes other problems, right? You go in for a hangnail and end up losing the finger. That's never a good thing. So
and when we say radical, we're not meaning like totally gnarly. Hey,
no.
Yeah, not far out. We're not going Valley Girl on you.
And Shannon, you and I are probably the only ones old enough to know what that is. But no, radical prostatectomies, and we'll talk a little bit about that in just a second, the white paper around it. But she told me, she was very interested in the ability to be able to determine if her nerve sparing techniques worked. And if they didn't work, she would be able to immediately, direct that patient even before symptoms, really early on, that there were going to be issues because the nerves weren't working properly, and direct them to like a pelvic floor rehabilitation therapist or to a urologist that could help, work with different techniques to be able to stimulate those pelvic nerves. And that was incredibly interesting to her because she had never heard that there was a way for us to know that was working. The traditional way of doing a bulbocavernosa reflex test is a manual insertion and a squeezing of the glans penis or the vagina, and getting a response that you could feel. The problem is you really don't know if that response, if there was a number, like if there was a time that could tell you that there was a delay or if it was normal or not. And then after the surgery, you could still do the same technique, but you couldn't be able to compare the two because you didn't have a time. And the idea that there was a system that would allow them to do a test before the surgery and therefore after the surgery to determine if their nerve sparing techniques worked made a tremendous amount of sense for her as an oncologist who was doing these procedures.
And in fact, the white papers were using the Uraval BRS.
Correct. This conversation we had was something that another doctor said, you know what? I want to not only look into that, I want to also do a white paper. He was going to report what he did. So the paper, which we're going to link below, is specifically titled Electrodiagnosis of Erectile Dysfunction in Patients After Nerve-Sparing Radical Retropubic Prostatectomy, or what we call RRP, was performed. Now,
very, very long name.
Yes, very, very long.
Very medical E.
But the basis of this was a urologist, right, who was working with a patient or worked with lots of patients after they've already had the prostatectomy done by an oncologist, and then they're dealing with the symptoms of ED or other things, right? There's lots of symptoms that can happen after one of these prostatectomies. And he needed to know, is he dealing with erectile dysfunction that is neurogenetic, or is it another problem that a lot of men have with ED? Was it the prostatectomy that caused it, or was it a different problem? And that's what they needed to determine. And
And that was for treatment.
yes,
Okay.
yeah, that was so that the urologist could treat the patient that had this RRP previously, right? So you've got two different perspectives there. You've got the perspective that I had with this oncologist who wanted to know before they sent to the urologist whether or not this had happened, right? If the nerves had been spared or not. And you had the urologist who wanted to know if the nerves had been spared or not so they could determine proper treatment protocols. And we talk about neurogenetic based ED and neurogenetic based, incontinence all the time with this. And that's why a neurogenetic based test is so important, both on the oncology side, pre and post surgery, and to the urology side after they've come up with a patient that has RRP. And that's why this is such an interesting thing. And by the way, this white paper directly used the bulbocavenosa reflex system, the Urival, that we represent Amazon. And that's how come I, of course, know so much about it.
And the one nice thing with being able to have that information is, as we've talked about in past videos, is now instead of having, 5 different options, we can now move towards, well, not us personally, but our providers can now move towards eliminating some of those that aren't going to work. Instead of now we're going to try this and see if that works, try this, see if that works, try this and see if that works, and go straight to one that is 1, 2, or 3 that are going to have more success.
Right. A direct line to an effective treatment program. And I believe, like, again, we always talk that the BRS is designed for assessment purposes. That's its purpose, is to assess. For me, if I was an oncologist, I would love to have technology like this to be able to assess my patient pre and post surgery. Why? Because they may have had this problem before they came to have the prostatectomy. And then you don't want patients blaming you for something that you had nothing to do.
Yeah, good, very, very good point.
Right.
Yeah.
But more importantly, if the nerve, because they're going to have the prostatectomy, that's to save their life, right?
Mhm.
But if your nerve sparing techniques didn't work and the nerve was damaged a little bit, there are directions we can immediately send them, and we can know even before they really start having the major symptoms, that if we can direct them to fix these problems before they become big problems, we're really doing our patients a great service to be able to offer that kind of knowledge and insight into not only what happened in the surgery, but what we can do to make that surgical process afterwards more effective. Think of it this way: every time you go in for a shoulder surgery or something, where do they send you right after? PT.
Yep.
Right?
Yep.
They send you to physical therapy. Why? Because they know they probably messed a few things up. They probably
But
did.
also too, you have the X-ray before,
Right.
and you get the go to PT afterwards. So here we're doing the screening before. Now you're going and having the therapy or the treatment.
This isn't
So,
a huge leap for oncologists. It's just that 99.9% of them have no idea this technology even exists.
right.
And like I said, it's a very intriguing concept to be able to have that option as an oncologist, and something that I think, if it's an oncologist who's watching this video, they should reach out and talk to us a little bit, and we can give them some great information about the system.
And this has been extremely informative. I really appreciate, the subject matter of being able to talk to our oncologist providers out there. And if you have any other questions for us, please, we have a link in our comment section below. Reach out to us. We can, set you up with a time to be able to discuss further and be able to also share with you the white papers. We will have links to those in the comment section as well. Dr. Mike, I thank you very much for your time. Any last questions or any last thoughts?
Just to always be open to the idea of thinking ahead of the curve. There's lots of opportunities for people to do better patient outcomes and better treatment for our patients. And we want to always be mindful of those and be looking for those ways to help. That's what I'm about.
And we want to thank you again for watching the Dr. Mike and Shannon show. Don't forget to like, subscribe, and share, and have a wonderful day.
Have a great day. Bye.